Hello, my name is Frederik Wesseling. I'm a radiation oncologist at Maastricht, and in that role I'm part of the multidisciplinary team that diagnoses and treats patients with head and neck cancer. And today I want to present to you a case of a patient with hypopharyngeal cancer to show you the steps that we take to diagnose and to stage this type of head and neck cancer, and to discuss which type of treatment we want to present to this patient. So the first impression is already important, to see which patient we have and to think about which treatment options are available for this patient. So in this case we have a female of 67 years old. She has not average height, a normal weight. She is a retired teacher and she smoked before, about 28 pack years. She stopped several years ago, and she drinks about 1 to 2 alcoholic beverages every day. She has a good general performance score, WHO score of 0, and she has no relevant medical history. So this is the ideal patient. This patient went to the general practitioner. She noticed a growing mass at the right side of her neck, and she has a sore throat for several weeks. So the general practitioner started antibiotics, but this had no improvement on her complaints. So now she was sent to the ENT department. And when we speak to her, she complains about a painful burning feeling at the back of her throat and sometimes aspiration of fluids. So when she wants to drink something, she has to cough. And because of those swallowing complaints, she had lost about 4 kilograms of weight in the last 3 months. So in this case, we have suspicion of head and neck cancer. And there are several steps that we wanted to do. Physical examination starts with inspection of the oral cavity. We continue with a flexible panendoscopy in which we can inspect the lower parts of the head and neck area. And we conclude with a palpation of the neck lymph nodes. So inspection of the oral cavity is to have an impression of the general health of the mucosa, of the teeth, to see if there are any missing teeth, if there are any infections that can give problems during treatment, but also to look for ulcerations or masses. So to see if there is a primary tumor in the oral cavity. In this case, it's like this. We just see a healthy mouth, no abnormalities. Then we continue with our flexible panendoscopy. So with a video scope or with a fiber optic flexible scope, we can enter the nasal cavity and we can go inside and inspect the nasopharynx, the oropharynx, the hypopharynx and the larynx. And we want to look also for ulcerations or masses, but we also want to evaluate the normal function of the larynx, the swallowing function, and have an impression of the vocal quality. This is how it should look. So we go quite deep into the nose and we enter the larynx. At the bottom we see the base of the tongue. We see the epiglottis, which closes when we swallow. And in the back we see the vocal box with the vocal folds. So when we swallow, this epiglottis closes so that the food and the drinks goes into the esophagus and not into the airway. At the side of the vocal box we see the piriform sinus at both sides, and at the upper part we see the entrance of the esophagus. In this case, so this is the prior picture, we are at the right side of the vocal box, and we see here a bit of a strange color of the mucosa. There's an ulcerative mass, and this is the piriform sinus, and it's the medial wall of the piriform sinus. We measure this for about 3 by 2 centimeters. What we also see is that the right arytenoid is a bit swollen. So this suggests that there is invasion from the piriform sinus into the larynx. And this causes impaired movement of this side of the larynx. So when the patient makes some voice, the left part is going to the middle, but the right part is standing a bit sidewards. Then we go to the palpation of the neck lymph nodes. What we want to do is we want to feel the lymph nodes and search for lymph node metastases. So we want to feel if there are any lymph nodes that are enlarged or if they are hardened. We also want to see if we can move them or if they are fixed to the skin or to the deeper parts of the neck. And what we want to do is to distinguish between malignant lymph nodes or reactive enlarged lymph nodes, which could be in case of infections. The difference between both is that the malignant lymph nodes mostly are hard and not painful, but reactive lymph nodes are softer, so more tender, and mostly painful when we palpate. So in this case, at the right side of the neck, in level 2 and 3, we have one mass of about 4 by 4 centimeters, and we can move this easily. And there were no enlarged lymph nodes at the other side, at the left side of the neck. So next what we want to do is to have some radiology exams. And in Maastricht we have the division of tumors that are laying above the hyoid bone, the upper part of the head and neck area. We prefer MRI scans, because on MRI we can better distinguish the different soft tissues. So for example, tumor from mucosa or tumor from muscle. At the lower part, so below the hyoid bone, we prefer CT scans, because on CT scan we can better distinguish tumor from harder tissue like bone or cartilage. In this case, we have a tumor at the piriform sinus, which is in this area, so then we prefer CT scan. That's what we did. For all patients with head and neck cancer, we want to perform ultrasound of the neck lymph nodes, just to see if the enlarged lymph nodes are also suspicious on ultrasound, but also to perform fine needle aspiration to confirm malignancy in the enlarged lymph nodes. And at the end, we also want to see if there are distant metastases or second primary tumors, and we want to perform images of the lungs. If we have low suspicious of secondary tumors or metastases, we perform a chest X-ray. So this is in the lower tumor stages. But if we have a larger tumor or larger lymph nodes or multiple lymph nodes, then the chances of metastases are higher. And then we perform a CT scan of the lungs. So this is what we did, CT scan of the head and neck area. We see the same mass as by the inspection at the right piriform sinus. The radiologist measures this as 2.6 centimeters in diameter. Also have the thought that this is arising from the medial wall of the piriform sinus. And they also see this enlarged lymph node, and on CT scan this was 2.8 centimeters in diameter. No signs of extranodal growth. Then they performed a neck ultrasound, and they also see the enlarged lymph node at the right level 2 to 3. They performed fine needle aspiration, so they took out some cells to investigate and search for malignancy. There were no enlarged lymph nodes at the left side of the neck. And at the end there is the chest CT scan, in which they search for suspicious pulmonary lesions, but in this case this was all normal. So no signs of secondary primary tumors and no signs of metastases. We always want to perform some lab and pathology tests. So there are some general blood tests to have an impression of the general health status of the patient, but also to see if this patient is able to undergo chemotherapy, because in that case you need a good renal function. So the renal function is the most important part of this lab. In this case, all is fine, so no problems with our blood. Then we continue from the biopsies of the primary tumor and the cytology of the neck lymph nodes. The primary tumor is to confirm malignancy at the place of the mass and to exclude inflammation, which can also give ulceration or masses, but also to exclude other types of cancer, other malignancy like lymphomas that are treated differently. So just to confirm the real head and neck cancer. We can also stain for subtypes of cancer. For example, in oropharyngeal cancer, we can stain for P16 or perform HPV PCR testing, which is just a better prognostic subtype of oropharyngeal cancer. In this case, we have this biopsy of the right piriform sinus, and squamous cell carcinoma is confirmed, which was in this case a high-grade tumor. And we also have the fine needle cytology, just to confirm that the large lymph nodes contain tumor cells and to exclude enlarged nodes secondary to an infection. And in this case also the same squamous cell carcinoma was found in the enlarged lymph nodes. Then we come together to our multidisciplinary tumor board. We discuss all investigations, the complaints and the physical examination of this patient, and we have to stage the tumor. We do this by the TNM staging system, which is quite impressive if you read this for the first time. It's different for every subtype of the head and neck area. So every part of the head and neck area has its own TNM staging. For this case, we want to simplify this a bit, so we made a simplified TNM stage. And in this case, we had this tumor of about 3 centimeters in diameter with impaired laryngeal mobility. So there was growth into the larynx, fixed larynx. In this case, this makes this a T3 tumor. We saw enlarged lymph nodes, but they're all smaller than 3 centimeters. Mostly what we feel is an overestimation. So the 4 centimeters on palpation is an overestimation. So the 3 centimeters on radiology is what we use for our TNM staging. There was no extranodal growth, so we conclude this to an N2 stage. No distant metastases, so concluding staging of this patient is a T3, N2, M0 hypopharyngeal carcinoma arising from the right piriform sinus. Next step is to see which treatment options we have for this patient. And we have about 3 large groups of treatment. For the smaller tumors, like the T1 and the T2, without lymph node invasion, we have local regional radiotherapy as curative treatment options. If the tumor is a bit larger, or there is more invasion in surrounding tissue, or if we see lymph node metastases, so T3 to T4 or N1, N2, then we want to perform chemoradiation. So we want to add chemotherapy to the weeks of radiation to make the treatment more effective. But we can only do this when the patient is of younger age, so below 70 years old, good general condition, so WHO PS 0 to 1, and without serious comorbidities. So they have a good renal function, no cardiac complaints, then we can perform chemoradiation. Otherwise, we have local regional radiotherapy only, which could be curative as well. If we have N3 stage, so if there are quite large lymph nodes or there's extranodal growth, then we think that chemoradiation is necessary to cure this cancer. So if we have a patient that can undergo chemotherapy, then we want to perform chemoradiation. But if there's any reason that we cannot add chemotherapy, then we think that radiation only is not enough to cure this stage of cancer. And then we want to perform surgery up front. So first remove the lymph nodes, the entire neck is operated, and then afterwards we can perform local regional radiotherapy to try to cure this patient. So in this case, T3, N2, M0, age below 70, good renal function and no comorbidities, then we have chemoradiation as the first treatment choice to present to this patient. So to conclude, we have the general condition of the patient, excluding comorbidities. We have our clinical examination in which we have a first impression of the T and the N stage, and sometimes also about the M stage. We perform radiology to confirm that the suspicion of physical examination is the location of the tumor and the location of the lymph nodes. We perform pathology to confirm the presence of malignancy. And then we conclude this all in the TNM stage, depending on the tumor site and sometimes also depending on subtypes, to select the best treatment options for this specific patient. So then we go back to the clinic, discuss the several treatment options, and perform shared decision making with the patient to select the best treatment option for this patient. And this is what I wanted to present. Thank you.